This is the Psychcast by MD Edge, where we bring you interviews with leaders in the fields of psychiatry and psychology, masterclass lectures, and relevant inspiration, with new episodes dropping on Wednesdays. I'm the voice of MD Edge Podcasts, Nick Andrews. Welcome to episode 107 of the Psychcast. I am Nick Andrews. This episode was originally published back on March 18th, 2020, in the midst of the COVID-19 explosion in the Western Hemisphere. Therefore, this episode is all about the virus and its impact on the field of psychiatry. We welcome Dr. Elspeth Richie, who will speak to that. And after Dr. Richie, stick around for Dr. Renee Kohansky, who is also going to talk about a COVID-19 topic, communal humanity resistance. Please know that MD Edge and Medscape are covering COVID-19 with our fullest editorial capacity. You can find that coverage at mdedge.com and medscape.com. Okay, let's get to episode 107. Please welcome the special lecturer, Dr. Elspeth Richie.
My name is Elspeth Cameron Richie. I am a psychiatrist and I also have a master's of public health. I've long had an interest in the psychiatric aspects of infectious disease. I am chair of psychiatry at MedStar Washington Hospital Center, and today I'm going to talk about the psychological effects of COVID-19 and what you can do with yourself, with your patients, with your fellow providers to mitigate some of the anxiety around this epidemic. I'm going to talk in several parts. I'm going to talk first about the fear and anxiety. I'm going to talk about quarantine and how to make that possible, especially in a population that may be addicted to drugs or alcohol. And I'm going to talk about what we need to think about for our psychiatric wards, how to protect ourselves and our staff. And then finally, I'm going to mention a little bit about the long-term effects that we've seen in other pandemics. I've been in this business for a long time. I was in the Army when we wrestled about issues around chemical and biological warfare in the first Gulf War. 9/11, of course, was the other major catastrophe. We didn't have the risk of infection, but shortly after that we had anthrax, and we've seen SARS and other viruses. So we have a pretty good feel about what usually happens in epidemics. So first of all, the fear and anxiety. An epidemic, especially in the beginning phases, is characterized by fear and anxiety, especially if you don't know if you've been exposed or if you don't know if you're shedding virus. And we tend to poo-poo, oh, it's a worried will, or at least we have other times, so I don't think we're doing it now. But if somebody doesn't know if they've been exposed or are passing the virus to others, then it's kind of a misnomer to call them worried well. They may be worried, but they don't know if they're well, and at the moment, we don't know if they're well. I don't know myself if I am shedding coronavirus. I don't know if I can be around my elderly parents. As a matter of fact, my mother's nursing home has just restricted me, no visitors, so that takes that off the table. Many people are worried about their children. In this case, we haven't seen children get sick, but we believe that children can be carriers. So again, that's a fear and anxiety. What can you do about that? Well, common sense things. Social distancing is a term being used a lot, and that's excellent. I no longer have to tell you not to shake hands. We're experimenting, we're joking, and joking can be a form of managing anxiety. Should I bow? Should I do a foot bump? So keeping some distance from your patients. In our clinic at the moment, we've rearranged our waiting rooms so that our chairs are further apart from each other. We have a program where people are fed lunch, an intensive outpatient program. We're spreading out the tables. We're trying to figure out whether to continue with group therapy or not. So think about common sense things. Another aspect to reduce fear is, what do you do that makes you feel better? Keep doing that, whether it's exercise, working in the garden, or whatever. Personally, I take zinc every day. I don't know whether zinc helps or whether it's a placebo effect, but I believe in placebo effects. They work. So what can we do to both acknowledge the fear of anxiety of ourselves, of our fellow providers, of our patients, and then take what we normally do to reduce anxiety? So that is kind of the immediate effect. Another area I've been interested in is how can we get people to self-quarantine and what should we advise them to do? And I think we're pretty good now at preparing for snow days, lay in enough water and food and toilet paper, other necessities. And I think the American public is already doing that. That's why the shelves are empty at the store of toilet paper and sanitizer. But also think about your own medications or your patient's psychiatric medications. Make sure that they have a supply so that if all of a sudden they or you have to go into quarantine, you'll have those at home. With some of our patients, they're addicted to alcohol or other drugs. Now, this gets harder. I jokingly, some 20 years ago, remember I've been in this business for a long time, would talk about horse-drawn wagons of beer, Clydesdale horses, of course, with bush beer, going around to different houses to make sure people don't venture out for a drink. I don't think we're ready to do that yet, but I think we need to think about how to make sure our alcohol-dependent patients have something to help them manage a withdrawal symptom, or indeed making sure that they have enough of whatever they need. Harder is patients who are on methadone. And, of course, traditionally you go to a methadone clinic daily. I don't know what to do about that at this point, other than to acknowledge it's an issue, and maybe we should consider dropping methadone off at the house if a person has a house. Now, the homeless population is a very tough subject. Of course, all the social distancing and maintaining the medications is really hard, but we need to think about how we would manage that. So that's the quarantine part. Another issue that we're grappling with right now is what to do about visitors and other sanitation on our psychiatric ward. Like many psychiatric wards, our ward is set up that patients eat in a community setting. They share bathrooms. They share bedrooms. And we don't have hand sanitizers on the walls because we're worried that patients will drink the hand sanitizer or light it on fire or do something else destructive. So we are really trying to figure out what to do to keep our patients and our staff safe. I was doing a Google search yesterday. I think we've all heard about the psychiatric ward in South Korea that eventually practically became a death camp. People were locked in there. Nearly everybody got the COVID virus and a number died, both patients and staff. How can we avoid that? And where we're looking at is not allowing visitors and trying to move towards some kind of video visitation as they have in many jails and prisons. But that takes a while to set up. And our telepsychiatry folks or telemedicine folks are very busy right now with other issues. But again, I'd encourage people to think about how they can make their psychiatric ward safer. One thing we're doing is we have several phones that are passed around from one patient to another, always a hot commodity. We're now having them signed in and out of the front desk and making sure they're wiped down. We have some experience with flu patients, but this is a major concern because if one person gets it on the ward, then given our close quarters, it will probably be a short period of time before everybody gets it, and then we won't have staff to run a psychiatric ward. So this is a major concern. Now, these fears may change over time, but that's sort of this week's concern is how to keep everything clean and sanitized. So as I mentioned, there's short, mid-range, and long-term effects, although in this particular pandemic it's hard to predict the exact sequence of when they roll out. We're taking a major hit right now on our tourism, our sports, our hotel industries, and some of the other epidemics such as SARS. This took a little while longer to roll out, but we're already facing major collapses of travel. And all my conferences have been canceled, and I'm assuming that's true for most of the people listening. So what we know from other events is that what happens when the tourism industry collapses is many people get laid off, and often these are people who are less skilled, perhaps immigrants, and they may have a harder time finding a job in other industries. And the long-term economic fallout of unemployment is often suicide, domestic violence, or depression, other features as to what will be the long-term impact. Coming back to the immediate, and again, I've been doing talks on this for some time. I talked about if there's an epidemic, we're going to fight over who gets the vaccines or who gets the lifeboats or who gets the face masks. And we're having that right now with the fight over face masks and hand sanitizers and other equipment. And I think we need to remind ourselves and our patients of the appropriate use of personal protective equipment, i.e., you should not be wearing a face mask just out and about. If you do, you'll probably have a higher likelihood, at least my infectious disease colleagues tell me, of catching it because you'll be fiddling with the mask and fiddling with your face, and it's really not designed to be protective against viruses from outside. If you are sick, you should certainly wear a face mask. So think about the impact that you may have when people fight over the protective equipment or the temptation to hoard or to squirrel everything away. And there's a balance here, as there is with most things, because you do want to have enough food and supplies to last you for a couple of weeks if you have to go into quarantine, but you don't want to be obsessive about it, and you don't want to reduce the supplies for other people. You don't want to be obsessive about it, and you don't want to reduce supplies to other people who really need it. So I'd like to close with a couple words about taking care of ourselves and our other healthcare providers that we work with on the front line. This is where the value of reaching out to others and yourself and reminding others and yourself of the importance of what you do. We are healthcare providers. We're on the front line. This is a major crisis. This is a time where it's really important for us to do whatever we can to fulfill our mission of taking care of others and ourselves. In terms of self-care, make sure that you get enough sleep. We know that a healthy immune system is more likely to fight off the virus. And make sure that you stay in touch, not literally, figuratively perhaps, with your family and friends. And finally, be flexible. I mentioned that I was supposed to be at a conference today, the American Academy of Geriatric Psychiatry, which was canceled. And then I was going to go down and visit my elderly mother today, but her nursing home has now said no visitors. So then I was going to work from home, and now I have to go brief my bosses about what we're going to do about COVID-19 and the psychiatry ward. And I anticipate that will be what life will be like for the next 2-3 months. We will have to be flexible. And if we prepare for that in advance, be prepared, be ready, be flexible, that's more likely to get both ourselves and our patients through this next few months. Thank you very much, and I'd really appreciate any comments or thoughts you have. I don't have the right answers. We're all working on this together, but we can learn from the past and the present and for the future.
And that concludes the lecture portion of our episode this week. Remember, this episode comes complete with show notes authored by Dr. Jacqueline Posada. The notes include an outline and links to references mentioned in the talk. When we come back, we'll hear from Dr. RK. Welcome back to the Psychcast. I am Nick Andrews. It's time now for Dr. RK.
Thanks, Nick, for the intro. I'm a voracious reader, and I get all sorts of information from a wide variety of sources. With all that is going on of late, I started thinking of an older issue, the Iran hostage crisis of 1979. In remembering that time, I realized I knew very little of the actual experience of the hostages. So I hunted down 2 books that were incredible reads, and I had to actually buy used hard copies. Let me tell you, I was up late every night for a week. The books were 444 Days, The Hostages Remember by Tim Wells, and Pieces of the Game, The Human Drama of Americans Held Hostage in Iran by Colonel Charles W. Scott. One was a direct primary source, and the other an incredibly well-researched compilation of information. So while the hostages lived the crisis, I and many listeners of this program followed their plight daily. As a psychiatrist now looking into the past then, these books provide an incredible opportunity to reach across time and touch history. These are not political books. They present these men's stories, and in Colonel Scott's book, offer an interesting, broader perspective of the situation. My words cannot do justice to their horrific experience. What an interesting psychiatric perspective is that even at times of extremists, they could distinguish behavior, actions, ideologies, manipulation, and propaganda. The movie Argo showcased the experiences of a small group of escaped hostages. As the books were written in the 1980s, that mission was still classified, and references to that mission are even quite intriguing. This is what I mean by a window that reaches across time. Here's the heart of the heart as a psychiatrist. I found their survival strategies positively compelling. For example, Colonel Thomas Schaefer spent 100 days in solitary confinement. Take a minute and think about that. 100 days in solitary in a foreign country, under duress, without another soul with whom to speak. Essentially, they were prisoners of war. One of the most important things he did was keep a daily record of how he was doing, and one of his parameters was self-evaluation. He said self-evaluation was the most important thing that helped him. At the end of each day, he'd asked himself, how did Tom Schaefer do today? Ultimately, when he decoded his diary, he found that about 90% of his days were number 3s on a scale of 1 to 5, or better. And then this would give him data for conversations with himself like, you're doing okay, or you're going to survive this. If you saw Argo, you're probably aware the hostages experienced a mock execution. They were forced against the wall, spread eagle, and the commands were shouted, ready, aim, fire. The guards dry fired their weapons with no ammo. It's actually truly hard to imagine, and it happened to them twice. Here's what Joe Hall, warrant officer, had to say. I realized a lot of things about myself that I'd never known before. I was more aware of my fiber. I'd never really been tested, but in Iran, I felt like we'd all been tested about as much as an individual can be tested. When you face the moment where you think you are going to be killed, I mean, come right up to that moment where you have to face death, that's an extreme test. It's about all anyone can ask of you. Facing something like that changes you. It really does. And I felt pretty good about myself. I'd stopped caring about whether or not they were going to kill us, and I think I was slowly preparing myself for the eventuality that we would never leave. I felt like I could go on for a long time and continue to survive. I knew it was possible we would never leave. Colonel Charles W. Scott discussed that under severe stress, the human willpower will become a floating line, and people can rationalize and consent to do things they would never otherwise do. So it was critical to establish personal goals and objectives before physical abuse began, so that line didn't float. He analyzed his situation and established his personal goals. What were the things he knew he could stand for? What were the things he could give up? Here are a few. No matter what they did to him, he would not write anything down for them. He would not say or do anything to embarrass his country, or say or do anything that would bring added danger or pressure to his fellow hostages. These were unbending lines in his mind that he knew he would not cross. We help guide people through some of the most difficult and trying times of their lives. I found these stories inspiring in reminding me of the strength of the human spirit, the importance of internal dialogue, collective culture, self-assessment, and truly radical acceptance. The whole of DBT talks about radical acceptance. These people, without the benefit of ever having had a DBT course in the entirety of their lives, were smack up against radical acceptance. We have the ability to withstand adversity that is stronger than we even know, and Mother Nature, as we see, has her own way of putting us to this test. Challenges are the journey, but we also need some very basic and simple tools, such as guidelines of personal ethics that are our own personal truths, learning to take inventory or self-evaluation, radical acceptance of what is. I'm Dr. Renee Kohansky for the MD Edge Psychcast.
And that concludes this edition of the Psychcast. It's time now for the credits. The Psychcast is hosted and produced by MD Edge Psychiatry Editor-in-Chief Dr. Lorenzo Norris. Our guest masterclass lecturer this week was Dr. Elspeth Ritchie. The Dr. RK segment is written, recorded, and produced by Dr. Renee Kohansky. The show notes are authored by Dr. Jacqueline Posada. The SciCast is produced by editors Gina Henderson and Jeff Bauer. All MDH podcasts are produced by our editor-in-chief, Dr. Ivan Aransky, as well as executive editors Kathy Skarbeck and Mary Ellen Schneider, and multimedia editor Terry Rudd. Social media is produced by Kyla Clark. I'm your audio engineer, audio editor, and the voice of MDH podcasts, Nick Andrews. You're listening to the SciCast.